Yes, last and certainly not least, I have the pleasure of introducing Catherine Campusano. She is a rising senior in the Northwestern University's honors program in medical education, majoring in neuroscience with a concentration in biology. The title of her presentation today is Hepatitis A and Hepatitis B serologies of marginalized populations living with hepatitis C. And a fun fact about her is that she has watched all of the Marvel movies chronologically and in order of release. Take it away.
Hello, everyone. My name is Catherine, and this summer I worked under Dr. Jennifer Price evaluating hepatitis A and hepatitis B exposure rates in people living with hepatitis C. So viral hepatitis is characterized as an infection that causes liver inflammation and damage. Chronic infection associated with hepatitis B virus or hepatitis C virus may result in cirrhosis, liver failure, or liver cancer with long-term progression signaled by the onset of symptoms. Hepatitis A virus does not cause chronic hepatitis. However, clinical symptoms of HAV can lead to acute liver failure and death in the absence of liver transplant. However, HAV does resolve spontaneously in most patients. Unlike hepatitis C, HAV and HBV have safe and effective vaccines. However, HBV incidents have been recorded in regions characterized as epicenters of the opioid crisis. And in addition, HAV outbreaks have been observed in populations who use drugs and are experiencing homelessness. This project aimed to improve portable data that selects for persons with contacts to healthcare systems using descriptive analysis to make comparisons between status groups, looking for differences by demographic and other factors. So serology data was pulled from medical records of participants enrolled in the Now No One Waits study and patients being treated on the Deliver Care mobile unit, with selection from street outreach recruitment that targeted people experiencing homelessness and injecting drugs for rapid HAV antibody testing, followed by confirmatory HCV RNA testing and treatment offered if they were positive. If not previously done, HBV serologies were obtained for all patients at the time of treatment initiation. However, HAV serologies were only obtained for those receiving care from the Deliver Care unit. 3 serological markers were used to evaluate HBV exposure: HBV surface antigen, HBV surface antibody, and HBV core antibody. The HAV immunoglobulin G antibody was used to evaluate immunity to HAV either from prior exposure or vaccination. And descriptive analysis to make comparisons between our status groups was undertaken using the StatB software to calculate the frequency of each exposure group, looking for differences by demographic and other factors, with data obtained from unique Deliver Care and Now study intake surveys. A total of 119 HBV serological profiles were available between the 2 HCV treatment settings. Exposure data reflected that 29% of our cohort remained susceptible to HBV infection, while 47.9% were immune due to prior infection and 22.7% were immune due to vaccination. A total of 62 HAV serology profiles were available through the Deliver Care patient population, with 12.9% of the population remaining susceptible to infection. In descriptive analysis, we looked at many variables, including ACE, RAGE, and current injection drug use. For example, the 2 that were significantly associated with HBV exposure were age and FIB4 scores. The youngest group, ages 24 to 40, were most likely to be immunized due to vaccination at 45.8%, and least likely to have prior exposure. However, 41.7% of that age group remained susceptible to infection. In contrast, the oldest group, ages 58 to 74, were least likely to be immune due to vaccination, but most likely to be immune due to prior exposure at 69.6%. Both HAV and HBV have safe and effective vaccines, yet 47% of the cohort had evidence of prior HBV infection, and 29.4% remained susceptible to HAV. Of note is the 41.7% of the youngest age group born after the development of the HPV vaccine that remain susceptible to infection. Also, our HAV data reflected that 12.9% of the cohort remains susceptible to infections. Our findings underscore the importance of HAV and HPV vaccination among populations at risk for HCV. A limitation of this study was the exclusion of those who were Hep B surface antigen positive, excluding those who were chronically or acutely infected with HPV. This could have resulted in an underestimation of HPV exposure in this population. The second limitation was our inability to distinguish those who had prior exposure to HPV from those who had immunity due to vaccination. Our next steps would include comparisons of exposure status in this population to the national average. These findings could result in further initiatives to increase HAV and HBV vaccination rates in marginalized populations in urban settings. Thank you.
Well done, Catherine. Very interesting work. It looks like Barry's got a first question for you.
Yes, I had a question about the vaccinations. I know there's a vaccine that works for HAV and HPV. I want to know, like, is that less effective than getting like a HAV vaccination? Or, yeah.
Sorry, you're saying that there is a vaccination that vaccinates HAV and HPV.
I probably read the article wrong, but it was some time ago, like during class or something. But I remember it was a vaccine that kind of for hepatitis A and B. Would that combination vaccine be less effective, or just do I have it wrong in my head?
I am not aware of any vaccines that are able to target both HAV and HPV simultaneously. But I could get back to you on that. I do know that at least for neonatal rates, data for neonatal immunization for HPV have actually shown that there is waning immunity as people get older, and that is actually something that was observed, not specifically the link between neonatal waning immunity through lifetime, but that there was evidence of this phenomenon called isolated core, wherein those who have waning immunity to HPV no longer exhibit the positive HPV surface antigen result. However, they do exhibit a positive surface core antibody result. And that's just because the vaccine is actually made, the Hep B vaccine is made using the surface antigen. So as their immunity wanes, that antibody is also going to wane.
Thank you.
Tam?
Hi, Catherine. You did a great job on your presentation. That's a lot of data and a lot of number. I want to ask because my project is mostly about hepatitis C, and I know that the common ways to have transmit is through bloodstream. So may I ask you know if Hep A and Hep C, the most common way to transmit, is it also through bloodstream, or is it also any other way that we might get Hep C?
Yeah, so in terms of Hep A and Hep B, which is what my projects were on, Hep A is usually spread through the stool of those who have hepatitis A. And so if it accidentally contaminates food or water, which is some outbreaks that have been seen outside of the homeless population and those who are injecting drugs, which is the data that I referenced at the beginning of my talk, have been seen like outside of those populations that we are serving with HCV treatment in San Francisco. However, similar to HCV, HBV is spread when blood, semen, or other fluids from somebody infected with the Hep B enters the body of somebody who isn't infected, and that is high risk factors for that, which is something that was in the large results table that I didn't have time to go over, is sexual contact and sharing needles and syringes or other injection drug use equipment.
Perfect, thank you.